Welcome to Fertility Doc Talk. I'm your host, Dr. Kaajal Abrol. I'm a board-certified obstetrician-gynecologist and fertility physician based in Toronto, Canada. My goal is to educate patients, partners, and the public on fertility, and to destigmatize infertility. Through this podcast, I aim to increase knowledge and awareness about reproductive health to empower people to make informed decisions about their own fertility. Welcome, everyone. In this episode, we are diving into in vitro fertilization, or IVF. IVF is a great fertility treatment option, one that can really help to increase pregnancy rates above naturally trying to conceive or other fertility treatment options. So let's talk all about IVF and understand what it is. How does IVF work? What are the different medication protocols that can be used? What are the indications for IVF? Are there any risks to doing this fertility treatment? These are all great questions to cover in a thorough discussion of in vitro fertilization. So let's get started. Let's talk about this and so much more. The process of IVF can be broken down into 4 main steps. First, the ovaries are stimulated with injectable fertility medications to grow and mature a number of eggs over the course of approximately 8 to 14 days. These medications include FSH hormone and sometimes also LH hormone. Another injection is also used to prevent ovulation, so the maturing eggs stay inside of your ovaries. This process of ovarian stimulation is monitored with serial blood work and ultrasound done every few days to look at ovarian follicle growth, blood hormone levels, and uterine lining. This is called cycle monitoring. As the follicle grows and the egg inside of it matures, the estrogen levels in the blood should rise and the uterine lining should thicken on ultrasound. Once ultrasound and blood work results look appropriate, a final injection called a trigger shot is given. It helps to complete the final step in maturing the eggs and triggers ovulation to occur. Before ovulation occurs, the second step is completed, the egg retrieval procedure. The egg retrieval is very specifically timed, usually 35 to 36 hours after the trigger shot, so that the eggs are retrieved just before ovulation will occur. During the egg retrieval, sedation medications are used to make patients comfortable. Then ultrasound is used to visualize the ovaries and the follicles, while a needle is passed through the wall of the vagina and into the ovaries, which are sitting just above the vagina in the pelvis. The needle is used to drain the fluid from the ovarian follicles. The fluid is then assessed under a microscope to find the eggs. Third, fertilization is completed. This may be completed through either traditional IVF or by intracytoplasmic sperm injection, also called ICSI or ICSI. In traditional IVF, each egg is placed in a petri dish, and many sperm, usually 50 to 100,000, are placed around each egg, and hopefully a single sperm penetrates the egg to start the process of fertilization. With ICSI, a single sperm is injected directly into a single mature egg. This is generally used when there are known sperm factor fertility issues, or perhaps when there were no obvious issues in the past, but a traditional IVF cycle resulted in poor fertilization. ICSI does not guarantee fertilization, but it helps with the first step, which is sperm getting into an egg. If fertilization occurs through IVF or through ICSI, an embryo may start to develop. The embryos are grown in the lab, in an incubator. Some embryos will stop growing or arrest at some point in their development, while others will grow to a day 3 embryo, and then others will grow even further to a day 5 embryo, called a blastocyst. The fourth step is embryo transfer. This is where an embryo is transferred into the uterus for potential implantation and development of a pregnancy. Hormone medication, usually progesterone, but possibly other medications, are used to prepare the uterine lining for potential implantation of an embryo. In some circumstances, embryos may be transferred on day 3. That is the 3rd day after egg retrieval. This may be due to poor development of embryos from day 3 to day 5 in the past, or a low embryo number in a current cycle, just to name a few possible reasons for choosing a day 3 embryo transfer. However, more commonly nowadays, embryos are transferred on day 5. That is the 5th day after egg retrieval. When embryos are transferred right away, days after the egg retrieval, it is called a fresh embryo transfer. Alternatively, embryos may be grown to day 5 or 6, or less commonly day 7 in some labs, and then frozen for transfer at a later time. When these frozen embryos are used, it is called a frozen embryo transfer, or FET. This hopefully gives you a good general sense of the different steps of an IVF cycle. So let's move on to learning some more about IVF, like the basic medication protocols that may be used. Each IVF protocol may start with stimulation around day 3 or 4 of the menstrual cycle. Or, quite commonly, it will start with some pretreatment, where a medication or more than one medication is given prior to the stimulation medications to help the ovaries respond to the stimulation medications. This pretreatment is often called priming. Oral contraceptive pills, which I will refer to as the pill, are commonly used as pretreatment. The pill allows physicians to time or schedule cycles to avoid specific dates or certain days of the week. It also suppresses the ovaries and reduces the occurrence of ovarian cysts that may be seen at the start of a cycle. And lastly, it helps to synchronize follicle growth, meaning the pill quiets the ovaries down so that when you stimulate the ovaries, you get a larger group of follicles growing at the same pace, increasing the chance that you will get more mature eggs from your egg retrieval procedure. Other possible pretreatments may include estrogen alone or a combination of estrogen and androgen. Both of these are often used in patients with lower ovarian reserve, where there may be a concern that the pill will suppress the ovaries too much and stunt follicle growth. Both of these options have also been shown to help synchronize follicle growth and get more follicles to grow in patients with lower egg reserve. There are 3 commonly used medication protocols for IVF. 1, a long Lupron protocol. 2, an antagonist protocol. And 3, a flare or microflare protocol. In an IVF medication protocol, there are 3 general types of medications used. 1, a medication to suppress the LH surge and ovulation. 2, an FSH medication, and often also an LH medication, to help stimulate the ovaries to mature a number of eggs, reflected in growth of the ovarian follicles. And 3, a trigger medication, which is a medication used to stimulate the final maturation of the eggs before egg retrieval. Sometimes even 2 trigger medications may be used as part of a protocol. In a long Lupron protocol, Lupron or a similar medication is used to first suppress the ovaries so that ovulation does not occur later on, once the eggs start to mature and the follicles start to grow. The stimulation medications are then added to help the eggs actually mature. In an antagonist protocol, the stimulation medications are started first. Once follicle growth is noted, then the antagonist medication is used to suppress ovulation, as it has a more immediate response and doesn't take time to suppress the ovaries like Lupron. In a flare protocol, the stimulation medications are given at the same time as the suppression medication. The suppression medication first causes a flare of the body's FSH and LH, which together with the FSH and LH medications given will hopefully kickstart the maturing of eggs. A long Lupron protocol is often used with patients with normal or average ovarian reserve. An antagonist protocol is quite versatile and probably the most widely used protocol right now. It is good for patients with low ovarian reserve, but also those with normal or high ovarian reserve. A flare protocol is ideal for patients with lower ovarian reserve. Let's continue down this path to learn more about IVF, like when it might be needed. Some of the common indications for IVF include unexplained infertility, being unsuccessful with more conservative fertility treatment, like controlled ovarian stimulation and IUI, low ovarian reserve, sperm factor fertility issues, particularly moderate to severe sperm factor issues, endometriosis, blocked fallopian tubes, a genetic condition requiring testing of embryos, and fertility preservation, so embryo freezing for medical or non-medical reasons. Some of the common reasons for an IVF and embryo freezing cycle, meaning no fresh embryo transfer, include a thin endometrium or thin lining of the uterus during an IVF cycle, or risk of ovarian hyperstimulation syndrome, or OHSS, or the need for genetic testing of the embryos, which is called pre-implantation genetic testing, or PGT. We will touch on both OHSS and PGT in a bit more detail shortly. Fertility preservation or embryo freezing for later use is another reason why one may not have a fresh embryo transfer, because trying to conceive now was not part of the immediate plan. Let's take a moment to review some of the potential risks and side effects of IVF. First, there are side effects of the medications, including injection site reactions like bruising or itching, bloating, breast tenderness, mood changes or mood swings, or headaches. There is also the risk of ovarian hyperstimulation syndrome, or OHSS, where the ovaries are so overstimulated that there's a variety of symptoms that may occur because of this, including significant abdominal pain and bloating, fluid buildup in the abdomen, diarrhea, vomiting, dehydration, and sometimes even an increased risk of blood clots. Next, there are complications from the egg retrieval procedure itself, including infection, bleeding, or injury to nearby organs like the bowel or the bladder. These risks are very uncommon, but good to be aware of. Finally, there are some risks related to the transfer, including the risk of multiples, particularly if transferring more than one embryo at a time, an increased risk of ectopic pregnancy, thought to be due to an increase in tubal factor fertility issues in patients undergoing IVF, and a slight increased risk of preterm birth or a baby born with low birth weight. It seems natural to now talk about success rates from IVF, but this is a tricky subject to tackle. IVF success rates depend on so many factors. Most importantly is age of the eggs. But ovarian reserve, sperm quality, and other reasons for fertility challenges will also play a role and may influence any age-related success rates. It's important to review your results and expected prognosis with your physician so you're prepared going into IVF. In general, success rates decline with increasing age of the eggs. A treatment add-on that may be considered when doing IVF is pre-implantation genetic testing, or PGT. PGT is a screening test that can be performed on embryos created via IVF to genetically analyze the embryos prior to transfer. There are two types of general PGT, PGT-A and PGT-M. PGT-A analyzes embryos for the correct number of chromosomes, the DNA molecules that hold your genes or the genetic information for your body. By identifying embryos with the correct chromosome number, the idea is to reduce the chances of a failed implantation and reduce the chances of a miscarriage. PGT-M analyzes embryos for a specific genetic condition that has been identified in a family, one that is caused by a defect in a single gene, not a group of genes. PGT is mostly done on day 5, when 5 to 6 cells are biopsied from each embryo and then analyzed. Now let's take some time to go through some common questions I hear about IVF to better understand this remarkable treatment option. First, does IVF increase my risk of miscarriage? Miscarriage rates are similar after IVF as after natural conception. The most important determinant of this risk is the age of the eggs. Risk of miscarriage goes up with increasing age of the eggs, whereby it is about 15% under age 35, and as high as 30 to 40% by age 40, and almost 50% by age 43. The next question I want to address is, will IVF prevent the possibility of an ectopic pregnancy? I think this is a good question to speak about, as people commonly think that IVF prevents the chance of an ectopic pregnancy, a pregnancy that implants outside of the uterus, most commonly in the fallopian tubes. This thought makes sense since the embryo is being placed right into the uterus in IVF, bypassing the need for the egg and sperm to meet and fertilize in one of the fallopian tubes. But the reality is that IVF does not eliminate the possibility of an ectopic pregnancy. How does an ectopic happen after IVF? Well, the embryo moves around for a bit after transfer, before it implants in the uterine lining. So it is possible that it moves towards one of the fallopian tubes and implants there. Although they aren't too common, ectopic pregnancies can still occur after IVF and an embryo transfer. Another very common question I hear is, why did we only retrieve 10 eggs when I was told my follicle count was 20? This is a really great question and such an important concept to understand when going through IVF. Although exact numbers are going to vary from patient to patient, let us talk about why the number of follicles you have at the start of an IVF cycle does not equal the number of eggs that will be retrieved after ovarian stimulation. The real question here is, why don't all antral follicles respond to medication and lead to a mature follicle and egg? To refresh our memories, antral follicles are small fluid-filled sacs that each contain an immature egg. The number of antral follicles sitting near the surface of the ovary at the start of a menstrual cycle, so day 2, 3, or 4, is a proportion of the total number of follicles inside the ovary. When the ovary is stimulated during an IVF cycle, only some of the antral follicles will respond to the medications and start to mature the egg inside of that follicle. The follicle will then grow in size and produce estrogen. It is difficult to predict exactly what percentage of the antral follicles will respond to stimulation, as this varies cycle to cycle and patient to patient. I often see an average response rate of about 40 to 50%, but this is super variable and can be more or less than this. Follicles grow at different rates, which means that when we proceed to an egg retrieval, not every follicle will be mature and have an egg ready for retrieval. For those that do have an egg, not every egg will be mature, meaning one that is able to be fertilized with sperm. So if we look at the initial example in the question and use these details that I've just described, 20 antral follicles may lead to 11 medium and large follicles during stimulation, which may lead to 10 eggs retrieved, which may then result in 8 mature eggs to fertilize with sperm. So this explains how 20 antral follicles may result in about 10 eggs being retrieved in an IVF cycle. Another common question I hear is, why do I only have 2 embryos when I started with 10 eggs? Again, exact numbers will vary from patient to patient, but let us talk about why we see a drop in numbers when going from eggs to embryos in an IVF cycle. The real question here is, why don't all eggs result in embryos? The answer is IVF attrition, or also known as the IVF funnel. This is a normal process by which there is a gradual decrease in numbers as eggs are fertilized and embryos develop in the lab. What are the different points in an IVF cycle where there is a decrease in numbers? 1. Maturity. Not all eggs retrieved are mature, and only mature eggs will fertilize with sperm. Ideally, there is about an 80% maturity rate. 2. Fertilization. Not all eggs will fertilize normally, by traditional IVF or by ICSI. Ideally, there would be about an 80% fertilization rate. And 3. Embryo development. Not all embryos will grow from day 1 of fertilization to the day 3 embryo stage to the day 5 or 6 blastocyst stage. Ideally, there is about a 30 to 50% growth rate from day 1 to day 5 or 6. So if we look at the initial example in the question and use these details on when drops in numbers occur, 10 eggs retrieved may lead to 8 mature eggs, which may lead to 6 normally fertilized eggs, which may result in 2 to 3 blastocysts at day 5. So this explains how 10 eggs may result in 2 embryos in an IVF cycle. It's important to remember that these are average numbers to expect. Attrition could be a little better or a little worse than these rates, and other factors like egg or sperm quality may affect the attrition rate. An interesting question I sometimes hear is this a good response for an IVF cycle? Or asked another way, what is the right number of follicles to develop in an IVF cycle? Or maybe even, how many eggs do most people get in an IVF cycle? Whatever the variation of the question, it's not an easy or straightforward one to answer, mainly because there is no right answer. What would be considered a good response is a very individual thing. It depends on your ovarian reserve and your previous response to medication if you've ever done a previous treatment cycle. So what is good for one patient is not always realistic for another. Or what's expected in one patient is not always what would be predicted for someone else. The question should probably be, is this a good response for my IVF cycle? And that question can be answered by speaking to your physician, discussing your results and any previous treatment cycles, discussing your prognosis and setting your expectations for an IVF cycle. Lastly, I am often asked a question that I think is important to address as part of this thorough discussion of IVF. Will IVF and the fertility medications used increase my risk of cancer? This is a very common concern for patients, regardless of their age or their family history of cancer. It's understandable, too, having concerns, given that hormone medications are used to stimulate your ovaries in IVF. However, current research does not show a link between fertility medications and an increased risk of cancer, specifically ovarian, uterine, or breast cancer. So there you have it, an overview of in vitro fertilization, a complex series of steps that starts with stimulating the ovaries to produce a number of mature eggs, leads to uniting eggs and sperm outside of the body in a lab, and culminates in the transfer of embryos into the uterus for potential pregnancy. It's important to understand what IVF is, what medication protocols are available, and what is recommended for you, and what your prognosis is for IVF based on your unique situation. I hope this episode was useful in allowing you to better understand in vitro fertilization and how it works to overcome many fertility challenges and improve pregnancy rates a great deal. That's it for this episode of Fertility Doc Talk. I really hope you enjoyed listening and learning and feel empowered about your reproductive health. If you enjoyed this episode, please remember to subscribe to the podcast and tune in to our next episode.